Today our lecture is on the hip and the pelvis. Our objectives are to identify the anatomy of the hip and pelvis, display an understanding of hip biomechanics and the effects of ambulation and function, discuss the function of the labrum of the hip and how it differs from the shoulder, display an understanding of FAI, symptoms, diagnosis, and treatment, identify hip pathologies related to adolescent athlete, discuss overuse injuries to the hip and the thigh, display an understanding of pubic arthralgia, the etiology, the diagnosis, and the treatment. The pelvic anatomy. The pelvis is formed by the left and right innominate, the sacrum, and the coccyx. This functions to support the spine and the trunk and to transfer body weight to the lower extremities. This also serves as an attachment site for muscles of the trunk and the thigh. The innominate is three bones that are formed by ossification and fused, which is early in life. It's made of the ilium, the ischium, and the pubis. We have the sacrum, which is a wedge-shaped bone composed of 5 fused vertebrae, which is attached to the ilium by strong ligaments. And then finally the coccyx, which is 4 or 5 small fused vertebrae that articulate with the inferior sacrum. So again, here's our anatomy. We have the ilium, we have the iliac crest, so that's the large bone at the top. We have the acetabulum here, and you see how the 3 bones come together here. So the ilium, the ischium, and the pubis. And then we have the obturator foramen, which is the foramen, which is the hole in the pelvis. And we have the ischium and the pubis here. And so this is the lateral view, this is the medial view. And so the inside of it and outside of it are all filled up with muscle here. And then it gives you that cavity in which your lower pelvic organs fit. Looking at the hip joint, or the femoroacetabular joint, it's an articulation of the acetabulum and the spherical head of the femur. So the acetabulum is a deep socket, as we said, at the confluence of the ilium, the ischium, and the pubis, forms an incomplete bony ring with a notch in the lower aspect, which is completed by the transverse ligament. So the acetabulum faces a bit forward, a little downward, and a bit laterally. The femoral head forms an angle with the femoral neck and the shaft of the femur, which is about 125 degrees. So you see here on the left we have a normal one. So that angle here is about 125 degrees. So I'm sorry, the normal is in the middle with 125. You have coccyvalgia to the right, which is greater than 125 degrees. So this one's 140 degrees. So that's going to put increased pressure on the joint. So that's going to put pressure into the acetabulum. And those people will wear down that acetabulum quicker, become osteoarthritic there. And then coxivara is where you have less than 125 degrees. So that shows, I think, that looks like 115 here. So that's going to put more pressure on the neck here. And so that's going to be more likely to shear off here or break off here. And here's a picture. Oops, skipped too far. Here is a picture of, or a radiograph. And so you see how the pelvis basically sits on top of the femoral head. And so you can see if you have too much of an angle here, that's going to shear that down this way. If the angle is too much out here, then that's going to put more pressure up into the acetabulum. So we need to have that 125 degree angle here so that pelvis will sit just right on the articular surface of the femur. Now let's look at the hip musculature. So we have anterior, posterior, and then we'll also have more lateral musculature as well. So anteriorly we have the iliacus, which merges with the psoas to form a common tendon, what we call the iliopsoas, which then goes down and attaches to the lesser trochanter on the femur here. And so the iliacus fills in this rim, the inner rim of the ilium. That's how it's got its name. And then the psoas major goes up and attaches to the lower vertebrae of the back. So it is a hip flexor. It is also will cause some hip or extension to occur in the lumbar spine. This is the reason that doing full sit-ups typically is bad. because we're pulling on the lower lumbar vertebrae as you're flexing the hip as you're coming all the way up. So if you have somebody that has some back issues, you definitely don't want them putting pressure on those lower lumbar vertebrae. And then posteriorly we have the gluteus max, and then we have 6 deep external rotators of the hip. So the one that we typically think of is the piriformis here. We also have the obturator internus and externus, the gemellus superior and inferior, and then lastly the quadratus femoris. These have been termed by some as the rotator cuff of the hip. And then laterally we'll have the other gluteal muscles, the gluteus medius and minimus, and then the tensor fasciae latae. And then the biomechanics of the hip. So during ambulation, the closed chain movement about the pelvis occurs in 3 planes. So in the frontal plane, we have the center of gravity, which is superior to the hip joint, creating a lever arm that produces an adductor movement. So here we have our center of gravity up here, we have our joint line over here, and you see the lever arm that we have here is fairly short, so these muscles should have a good advantage. But then what happens is if these muscles are weak and can't hold the pelvis here laterally, then the pelvis wants to drop here, creating an adductor moment at the hip. So that's the femur moving more medially. So the femur can move more medially, or the pelvis can move more towards the femur in a closed chain situation. And we have a video down here that you can click on and watch from the class notes. You can't get it from this video. And in the sagittal plane, the anterior and posterior pelvic tilt, which is primarily controlled by the abs and the glutes. And then in the transverse plane, we have internal rotation, which occurs at the hip on the stance leg as the pelvis rotates forward to allow greater stride length. So this is eccentrically controlled by the hip external rotators, mainly the piriformis we think of and the other deep rotators there. And you'll also, if you have somebody that has a loss of hip internal rotation, so you'll see less pelvic excursion as they walk. And usually you should see the pelvis move forward and backwards as they walk, but these people, basically their legs move and their pelvis does not. Now let's discuss the hip labrum. So the labrum functions to seal the hip joint. It creates a hydrostatic fluid pressure in the interarticular space. This equalizes the pressure on the joint surfaces and reduces overall wear. This also enhances the lubrication of the joint. At a 90-degree position of the hip is where most of the pressure is on at the labrum. So if you have somebody with a hip labrum issue, you don't want them doing deep squats. You don't want them sitting prolonged periods of time in class or at a computer and sitting in an upright position where their hip is at 90 degrees. So here's a picture of labrum. It looks very similar to the labrum of the shoulder because the tissue that forms the labrum is the exact same tissue. It's fibrocartilage, just like in the labrum of the shoulder. So the shoulder labrum and the hip labrum are really different in their function. So the shoulder labrum adds depth to the shallow glenoid. You can see here in comparison the acetabulum is very deep, so you have a good deep socket, so you don't need that labrum to act as to deepen the socket. And then the shoulder labrum, remember it looks like a chalk block, so it prevents excess humeral translation. But again, the socket prevents this translation in the hip. And then lastly, we talked a second ago that it seals that ball and socket. So it forms that hydrostatic pressure seal. That's not really the function of the shoulder labrum at all. So that's the main function that you need to know that the hip labrum does, is it creates a seal between the ball and the socket. Now let's talk about FAI, or femoral acetabular impingement. This is a fairly new term, something that I've just come across in the last 5 to 10 years. This occurs when abnormal contact between the acetabulum and the femoral neck and the head junction occur. The contact may occur in normal range of motion due to the osseous abnormalities of the acetabulum or the femur. This typically occurs with healthy active adults. A lot of times you see them 25 to 50. But we're starting to see them younger. We have 2 freshmen on campus in the fall semester of 2015 who have had hip scopes in the past to repair their hip labrum from FAI. And we have one of them is actually getting a revision this week. And then we have one of our other female basketball players that had one this off season. So this usually is involved with sports that have extreme range of motion. So you think of ice hockey, especially goalies, how they're always up and down on their knees and sitting in that position where they're putting a lot more stress on their hips. Martial arts, some track and field events, especially throwing events where there's a lot of deep squatting and pivoting. So these individuals will complain of dull, aching pain in their anterior hip and groin. This is often worse after prolonged rest or sitting. And it's typically an insidious onset, so it's not something that, such as labrum of the shoulder from a dislocation, that you have something traumatic. It's more of it occurs over time. So you'll have a positive anterior impingement sign. We'll go over that in lab. Diagnostic testing is important, so you take an x-ray to see the bony configuration of the femoral neck. An MRI usually doesn't show much on these. You really have to have an arthrogram where they inject a fluid into the joint, and so if that labrum is not forming the seal, then it's going to allow that fluid to leak out, and then that fluid is going to be picked up on the MRI. So an arthrogram is really important to get, not just a straight MRI. So our management starts off with conservative treatment, physical therapy for range of motion and strengthening. Often they'll do an intra-articular injection, and then surgical intervention where they do an arthroscopic repair of the labrum. They may have to take down excess bone off of the femoral neck or reshape the humeral head or take off bone off of the acetabulum. And then rehabilitation afterwards is really physician guided. And then there's another YouTube video that you can watch. Now let's look at some adolescent hip injuries. So Legg-Calvé-Perthes disease. So it's AVN or avascular necrosis of the femoral head. This occurs in young boys 4 to 10. The head of the femur flattens out as a result of the necrosis of the articular cartilage. Trauma only accounts for about a quarter of these cases, and it usually develops over several months and with a slow progression or worsening. They present with pain in the groin, with the medial knee or the abdomen. You'll see an antalgic gait pattern in which they are limping and limited range of motion. It's really important anytime you have a young boy complain of medial knee pain, you're always going to check out the hip, make sure nothing's going on at the hip, because the medial knee is a very common site for them to have pain referral. That's a very common pain referral pattern. So treat these with non-weight bearing, which allows the hip to revascularize and ossify. Lack of proper management will result in hip osteoarthritis later on in life, and that's going to be early osteoarthritis, so they're not waiting until their 60s or 70s to develop. That's probably developing in the 40s or 50s or maybe even as early as the 30s. So here's a picture, a radiographic picture. So you see how this just looks like it's falling apart here on the right side, how it's just disintegrating from that AVN. You see on this side, it looks like a fracture line right there, but that's the epiphyseal plate. It's a growth plate, so that's very normal there, so don't be thrown off. It looks like something's going on there on this individual's right hip. It's actually on the left. Now a SCFE, a slipped capital femoral epiphysis. So the femoral head slippage at the growth plate occurs in boys aged 10 to 17. The physical characteristics are usually they're a bit overweight. They may be tall and thin. Trauma accounts for about 25% of these, and about a quarter of them we'll see in bilateral hips. Very similar complaints and presentation as Legg-Calvé-Perthes. They'll have limitations with range of motion, especially abduction, flexion, and internal rotation. You can treat a minor slippage just with rest and non-weight bearing, but typically with these, especially in an athletic population, if they have a significant slippage, they're going to need an ORIF, or an open reduction internal fixation, in which they have surgical intervention. They may put a rod or a nail or a screw in there to hold it in place. So you can see the skiffy here again on your right, the patient's left. You see the femoral head, and you see where this growth plate is shifted, and now the femoral neck is actually almost even, or almost superior to the upper edge of the acetabulum. And again, you see the normal side, you see the growth plate here, you see the good rounding and contact with that. So that's a skiffy there on your right. Now let's look at some overuse syndromes. So iliotibial band syndrome, ITB syndrome. An increased hip adduction and knee internal rotation is the likely results in an increased strain on the iliotibial band. Most likely results from hip weakness. And you can have IT band syndrome proximally over the greater trochanter, or you may have it distally down at the lateral condyle of the knee. So you can have it anywhere, proximal or superior. You may have some soft tissue dysfunction down through the full length of the IT band, or they may have some tenderness the full length, but typically it'll be one end or the other. And those are two high friction points for the iliotibial band as it crosses the greater trochanter, and then distally as it crosses the lateral condyle. So runners with IT band syndrome exhibited significant reduction in hip abductor muscle strength in the affected limb compared to healthy controls. So this was in a study from Ferber et al. In 2010. And so what they did is they gave a 6-week hip abductor strengthening program, and 22 of the 24 runners increased their strength as much as 50% and were able to return to pain-free running. Typically on these, the physicians will tell the patient that they just need to stretch their IT band, that their IT band is tight. I'm of the mind that the IT band is not get tight, nor am I of the mind that if it is tight, that we can effectively stretch it and lengthen it in any way that would be measurable and helpful. Really comes from a lack of strength on these patients. So if you focus entirely on symptoms and you work on doing soft tissue mobilization, ultrasound, maybe you do some iontophoresis, and you're just treating those symptoms, maybe you're doing some stretching with them, that you're just not going to have as good a results if you don't look past their symptoms and look at what's causing the problem, which the problem is going to be hip abductor strength loss. Now let's look at the piriformis syndrome. So the piriformis is a hip external rotator. It is also a weak hip abductor and a weak hip flexor. It provides postural stability for ambulation and standing. In as much as 22% of the population, the sciatic nerve pierces or splits the piriformis muscle, but in fewer than 15% of these cases result from this anatomical feature. It's typically thought to be due to tightness or spasm, which creates compression on the sciatic nerve. It's often treated with NSAIDs, muscle relaxers, injections, surgical release, ultrasound, soft tissue mobilization, heat or cold. But the alternative theory put forth by Tonley et al. In 2010 is that the piriformis is functioning in an elongated position or is subject to high eccentric loads due to weakness of agonist muscles. So this is, again, a strength issue and not just a tightness issue or a spasm issue. We really got to get to the root of the problem and make sure that they are strong in the transverse plane as the pelvis rotates around the femur, stabilized femur as it's on the ground. It's often is overuse injury in runners, and again, it's most likely due to a weakness. Let's talk about sports hernia. That's kind of the popular term that pubic arthralgia has been given. So anytime you see in a newspaper article or online article or magazine, they're always going to refer this to a sports hernia. But if you see it in a journal or a academic journal or publication, you'll usually see pubic arthralgia. So sports hernia is probably one of the least understood, poorly defined, and under-researched maladies that we see. It's described as unexplained chronic groin pain. This occurs more frequently in males that are involved in athletic activities such as cutting, pivoting, kicking, sharp turns, so sports like soccer, ice hockey, or football. The likely causative factor is posterior inguinal wall weakening from excessive or high repetition shear forces applied through the pelvic attachments of poorly balanced hip adductor and abdominal muscle activation. It's characterized by insidious onset, so it's just gradual worsening. It's diffuse unilateral groin pain, may radiate to the perineum or the upper medial thigh. So it's kind of a similar location as what you'll see with FAI, but they're very different things going on there, very different causes. And a lot of these will end up with surgery. The diagnostic really doesn't do much for this, but it's good in ruling out other stuff. We got to make sure that it's not an inguinal hernia. Conservative treatment is pretty low, but treatment should focus on core strengthening, endurance, coordination, imbalances at the hip and the abdominal muscles, as well as dynamic stabilization of the pelvis. So these usually require surgery, as I mentioned a few seconds ago, and most literature shows that without surgical intervention, they're really not going to get better. I've only seen one of these. I've only had one athlete that's had it. What they did is they went in and they released his adductors, and I believe they released some muscles on the abdominal side of the pelvis as well. They usually do this laparoscopically. They usually don't do it surgically anymore. And that is our lecture for today. I will see you in class.